Hi, Diego.
Hey, Renee, how are you?
I'm well. How are you doing?
I am doing fantastic. Can't complain.
All right, that's good. After you open the meeting, I just have two quick announcements to make. I want to introduce Elisa Stetzer. It'll be her first PCP meeting. She's the woman who succeeded Daryl. And I just want to give a plug for the June 17th grand rounds. If that's
June.
okay with you.
Yeah, okay. Perfect. And okay, and you want everybody to put their name in the sidebar there for attendance?
Yes, please.
Okay. Okay. Okay, and okay, sounds good. No, I'm good with that. Let me get my video going here. I just realized I'm video less. There we go.
Hey, there you are.
So
I'm off intentionally because I'm shoving food in my face, but I'll be there in 2 seconds.
nice. Is it any good food? Anything you're gonna share through Zoom?
It's a sandwich. You don't want it, but it's sufficient for the moment.
Gotcha.
I had some pasta with a mushroom truffle sauce. That was fantastic.
Ooh, that
Sure,
does
go
sound
ahead,
good.
rub it in.
I will. I did. Hello, Doctors Smith and Newman. I see you.
Hello there. Hello there. Hi.
Hey, Chappie, I don't mean to ignore you. I know I owe you like a million responses to stuff. I will take care of Kathy Shannon tomorrow. I am just like behind the 8 ball today.
Trust me, I understand all too well, so I'm not
Mhm.
pressured in any way, shape, or form.
I bet. All right. Thanks, buddy.
No worries.
Hey, actually, as long as Renee and Chad are both here, first of all, Chad, congratulations.
Thank you.
I don't know exactly what you're doing, but I know you're doing
I
something.
don't either. That's the best part.
When do you start your new adventure?
May 1st. So I'm already
Oh, you're already doing it,
doing it.
but you're still doing this?
I am. So I'm trying to keep a foot in both canoes.
Oh, you are? Oh, okay. So you're going to keep doing this for a while.
Yep.
Okay. Okay. Well, this whole, thing with AHP, which I've been coming to for a year or so, which I enjoy, I usually learn a lot, but I am actually employed, I'm not private. But the way this all came about, Renee might remember, is when the discussion more on the pediatric side, the discussion came about. We used to have a town gown committee for pediatrics, which was the academic pediatricians and the community physicians. And they were talking about doing away with that and kind of using this as a substitute. So I really just wanted to make sure that it's still okay that we come to these and that's appropriate and whatever.
So
It's mostly for community docs, right?
no, so it's for everybody. So you're more than welcome.
Oh, it is for everybody.
Yeah,
Okay.
this is all AHP members. So yeah, come one.
Okay.
We're sorry.
technically-
I imagine that a lot of the talk about like the incentives seem to apply only to the
Yes,
private practice.
and I do sometimes, disregard that, but certainly any clinical information and whatever I appreciate. So, okay, I just wanted to make sure that was still okay. So.
And just to be clear, Lisa, the town and gown, so there's PCP advisory and there's PEDS advisory. There was some discussion, I think, a while back about turning PEDS advisory into the town and gown, but I think there was a general feeling that needed its own meeting. So there's a lot of stuff covered at PEDS or PEDS advisory that may also cross over into that town and gown discussion. But I believe the intent was to have a separate meeting for that.
Okay, yeah, that's interesting. I thought they got away from the town gown committee.
You very well may be right. The
Or maybe I
Honorable
just got
LJ
kicked
Kipley
off
would
of
know
it.
most.
As I recall, it was Rich Bloom who was running that. I'm
Rich
happy
Bloom was running it for a while, and at various times, before he retired, it was from Panorama.
Oh, McInerney, Dr. McInerney.
Yeah, Tom McInerney. Yeah, so it has, yeah, in fact, they would have like kind of a town in a gown. So I'll check into that. That's good to know. The discussion was, to kind of roll it into this, and that's how I sort of got involved. So,
I think there was a plan to try to resurrect that before the pandemic, and then.
that could be,
And so I think all discussion kind of went on hold, but LJ would know the future plans and of that, but
Okay,
there's enough overlap that come to PEDS advisory too. It's fun.
okay. Oh, yeah, I usually do. Yeah, I usually try to do both when I can. So,
They
okay.
sing songs and hug and cheer and do a lot of stuff. We don't do that here.
They actually don't. I went assuming that's what would happen, but it didn't.
No, you missed. I think when they were together, they did more hugging and singing. So. Zoom makes that difficult.
Yes.
And I would say that just to add to what Chad was saying, at this committee, with Steve and I both co-chairing, that's the whole point of having employed and private physicians on this committee. And
Oh,
so that we
okay.
address all the issues that are really affecting all of us in primary care.
Oh, okay. Okay, that's good. Yeah, that's true. That's true. Steve was kind of chairing some of these when I started, back in the day when it was in person. So,
Right.
okay, thanks.
Yep.
We got to give it a little more time, Diego. There's a lot more folks expected.
Yeah, sounds good.
Need more time to cram food in my face.
Chad, you have something on the right side of your cheek. Can you just wipe that off?
Oh, it's much worse than the right side. I'm eating like I got paid for it. So.
Hi, Dr. Bowler.
Hi, everyone.
We'll give it a couple more minutes to see who joins, and then we can start probably around 6:05.
I'm here.
Hey, no spaghetti sauce on the shirt. That's great.
Well, just not from like the top of my chest up. Who knows what happened?
Right. Don't stand up. Don't stand up.
Looks like a murder scene beneath that, huh?
Below the screen, all hell breaks loose. But
Looks like an autopsy.
luckily, there's only so much damage you can do with a peanut butter and jelly sandwich made by a 9-year-old. But the damage was done. We have strict child labor in my house.
Don't worry, they'll stop listening eventually.
Yeah, it's interesting about that Rochester City Ballet. My daughter really wanted to go see it because one of her friends is in it. And
Ooh.
all the shows are sold out all the weekend long. Of course,
So
it's gonna be thunderstorming and cold, so I didn't feel too badly about it myself.
I think I'm on mute, but I'm just saying. Oh gosh, any festival would be nice. Well, I guess the Lilac is on too.
Oh, it's a free view. Oh, I didn't know there was a free part.
Well, no, there's a free view. It's going to be far away.
Oh,
Bring your binoculars
oh, gotcha.
and have a picnic.
That sounds like a lot of work.
I forgot. There are some friends of my daughter's in the City Ballet too. They're probably in it. Olivia Bellavecqua, who went in the So You Think You Can Dance?
Oh, I didn't even know that.
Yeah. She made it onto the show with the 20 kids. But anyways, I'm just thinking outdoor shows are great.
Yeah, anything right now.
So I think we're going to go ahead and get started. It's 6:05, Renee. So welcome everyone to the PCP Advisory Committee for March. Renee, I believe you have some announcements for us to start off.
Sure, thank you. First of all, I wanted to mention that we have lost someone from our committee who's will no longer be attending. Dr. Cindy Tierlink was in the committee representing Naples Valley Family Practice. She has become employed by Thompson. And since Thompson has Dr. Landgraf representing them on this committee, she's decided to step away. So we certainly wish Dr. Tierlink well in her new endeavors. I am also would like to announce, while we're talking about comings and goings, that Kevin Kelly, who has been the provider relations liaison for about the past year. He started, I want to say, in January, and 3 months later, we were all at home from COVID. So he and I have not spent a lot of time in the same room together, but have worked closely together over the past year and a bit, a year and a half. And sad to say for my account, but happy for Kevin, he'll be moving on to a project management role, working with both Chad and Kim Povek, supporting AHP's clinical initiatives and IPCs. So we wish Kevin well, and this will probably be his last PCP Advisory Committee meeting, unless Kim or Chad punt him in front of you to avoid attending themselves. So we may see him, knowing them. And I also then wanted to promote folks, because the invitation itself hasn't gone out, but we have talked about it in Network News. We do have a clinical grand rounds on the calendar this coming June 17th. I think that's a Thursday night, 5:30, via Zoom only. It's going to be adult oriented, adult topics. We'll be getting out that invitation shortly. That'll have the agenda items and the speakers, but urge you that if you haven't already added that date to your calendar to please do that. And then finally, I want to turn it over to Daryl to introduce a new team member at AHP. Thanks, Daryl.
Sure. So thanks, Renee. So it's my pleasure to introduce Elisa Stetzer to all of you. Elisa is the new Senior Director of Care Management for Accountable Health Partners, for the Primary Care Administration, and also for the Medical Center. Elisa comes to the position, prior to this, she was overseeing care management, the Director of Care Management for the Primary Care Network, which are all the employed practices in primary care. And she's still overseeing the primary care network. She's just added in AHP Community and the rest of the medical center. Elisa has a very strong background in population health. She worked in medical surgical nursing at Strong prior to joining the PCA, and before that worked with the advisory board in Washington, DC, and also has provided consultation nationally for physician groups and health systems across the country. So she comes with a lot of great expertise and experience. She's been a very strong colleague in helping us build the care management organization. And I am confident that the care management infrastructure will continue to flourish with her capable leadership. So welcome, Elisa. And there you have it.
Thank you, Daryl. What a nice introduction. I really appreciate it. It's nice to be with you to my first meeting. Looking forward to getting to know this group a little bit better over time. So thanks.
Welcome, Alyssa. Make sure everybody puts your name in the chat for attendance purposes today. And I think with that, we'll move on to pharmacy strategy. Erica?
Okay, so just so you guys know, as much as I love you, you are standing between me and my vacation. So I'm gonna try to remain on time with my presentation and finish up at 6:35. I'm gonna talk a bit about our pharmacy strategy over the next 2 to 3 years. Here, hang on one second. Maybe. There we go. Are you seeing the slideshow?
Yes.
Yes, we are.
Okay, thank you. So I'm going to talk a little bit about the pharmacy strategy over the next 2 to 3 years. And then at the grand rounds that Renee talked about is where you'll hear a bit more about our pharmacy initiatives in this year and some of the new ones that we've selected for 2021. You can see I clearly don't even know what year it is. I'm so ready to be on vacation. It is in fact May of 2021. So, you know, our pharmacy vision remains the same at AHP to become a leader in improving population health and medication-related outcomes by promoting value-based prescribing and drug use. We want to design pharmacy services that are both patient-centered, but that also support clinician medication management. And when we originally put our strategy together, we designed 3 key strategies to go about this. The first was around creating an efficient drug utilization management program. The second was to integrate clinical pharmacists into ambulatory team-based care. And then the third is to start to partner to implement improvements to the medication use system around access, adherence with retail pharmacy partners. So when you think about what these strategies are designed to do, the first is really about reducing drug costs. Those are our pharmacy initiatives that we talk so much about. They have direct implication in reducing costs from year 1 to year 2, which is important in our value-based contracts because, you know, we need to sort of beat the annual budget by next year. So we try to design initiatives around sort of like low-hanging fruit in terms of outpatient prescribing, but we also do things in the medical spend arena here. Key strategy 2 is about getting the medications right. So it's about the right medication regimen, advancing with evidence-based medicine, and getting embedded pharmacists into the practices using the comprehensive medication management model has demonstrated that it can impact all areas of the quadruple aim around reducing costs, improving outcomes, as well as improving provider and patient experience. And then the last one around improving medication access and use, it ties in obviously with getting the medications right, because obviously you wouldn't want to optimize access or adherence to medications that were not optimal. There are some silo strategies out there in the pharmacy with some of my pharmacy friends that do in fact do that. So how could we tie these 2 things together and make sure that as we're getting the medications right, our patients can access the best drug for them and are able to take it as intended. And if we're able to do that successfully, that should have implications on cost as well as provider and patient experience. So kind of diving into key strategy 1, we want to create an efficient drug utilization management program. Again, these are our pharmacy initiatives. They reduce financial exposure to pharmacy costs in our contracts. And the way that I kind of broke this up is just by the activities that go under this strategy, whether or not it's activities that we're going to continue because we think, with our first pharmacy strategy that we put forward, we were doing a pretty bang up job and we want to continue it, or things that we think we could do better under the new category, or things that would be incrementally new. So every year we try to design at least 4 targets for reducing pharmacy spend. Again, this could be in the PCP prescribing area. Mostly it is in the adult space because we don't see as many high cost drugs in pediatrics. But also we've worked with specialists, we've worked on medical spend, implementing biosimilars in the hospital setting. So that's something that we want to continue. When you look at our cost avoidance, mainly with the Excelis contracts, that work that you guys all participate in with us, and we're so thankful for it, helps us to, like in the last year, have a cost avoidance of $4 million collectively. So we're appreciative. the next is, just really around that process. We've really established some great processes with Jenny, Katie, and myself around, looking for opportunities, also partnering with the payers. What are some of the drugs that are coming to market or new generics that we could substitute? Our big one in the last year was moving from brand Humalog to generic Humalog. And that generated around $2 million of savings thanks to Katie's great leadership on that initiative. We partnered with Wegmans and did some other things in the EMR to accomplish that. So we want to continue the process that we have around it because we think it's effective in identifying opportunities and taking action on them. We continue to quarterly track and report outcomes for these. So all three of these really tie together. We have a nice process. One of the things that we thought we could do a bit better is utilizing our pharmacy colleagues at URMC to identify more opportunities, particularly in the medical and specialty pharmacy spend areas. We have a pharmacy task force now has representatives from DME, home infusion, specialty pharmacy, outpatient pharmacy. So we take some of the opportunities there to see if there are ways in which we could identify opportunities and capitalize on them as partners. So another focus of our efforts really in this area is to increase real or near time access to our pharmacy claims data for decision making. So in the past, what we would have to do a lot of the work that I'm talking about is go out, ask for a flat file with the data, realize it was missing a bunch of data, ask for another file, so on. So it's by the end of the year, we're kind of like, okay, we finally got the data right and the year's over. So Christy has been extremely helpful along with her team to help us develop a pharmacy claims data mart, which is pulling from our value-based contract, all of the claims that are going through Excelis and MVP, all lines of business, so that we can see where we're spending money in the contracts so that we can find opportunities. We also have some contractual terms that were put in place where we're looking at putting a process together to identify really high spend drugs. So drugs that when you're looking compared to from last year to this year, we're spending $250,000 or more on a specific drug. So we're now going to have a list of those drugs to see if one, is there anything we can do about it? Or two, are there things that we can work with the payers to adjust for that? This is a snapshot of the pharmacy claims data mart. It's in Tableau, if you're familiar with Tableau. But it's really nice because we have a lot of different filters that are built around this where we can compare the previous total allowed amount for a drug class or specific drugs. We can see prescribers, which, sorry, that should be blinded. So just don't see that. And then don't worry, this isn't a full data set, so it's not accurate. It's an old draft. And you can filter by plan, by payer, prescriber type, etc., so that you can get detail to see how much has the total allowed amounts changed from year to year, how much has utilization changed, how much has the drug cost itself based on a 30-day RX changed. To get trends, patterns, find opportunities. If you were interested, we could sit down and look at this for your practice. We could look at this for yourself. If you were interested, we just did that actually with Stony Brook Pediatrics recently for something they were working on. But a useful tool. So another focus of our efforts for this key strategy is to be able to provide you with actionable level pharmacy data for the pharmacy initiatives that we work on. You may know right now, sometimes we email, sometimes we reach out through the EMR for opportunities. We'll likely continue that process for some things. But for a lot of the switch drug opportunities, what we're working on is with the provider engagement report, which you've all been acclimated to, is utilizing that to provide feedback for our initiative performance for some of the targeted PCP prescribed initiatives, as well as patient lists for patients that are on, the drugs that may cost more for consideration to change to less costly agents. So that will be a new activity going forward, and we hope that you enjoy that. We continue to offer, conducting visits with you in your practices, either to talk about pharmacy initiatives or anything related to updates in clinical guidelines that you might be interested in. You can reach out to us anytime to request those. That's part of collaborating with our practices to help with pharmacy prescribing. Also, and it just as a reminder, we also have the AHP pharmacist at urmc.rochester.edu. If you had any specific questions for us, that you could reach out to us that way if you don't have access to a pharmacist in your day-to-day. Some of the things that we have been wondering is if increasing access to the community EMRs where permitted could help for some of the outreach in the pharmacy initiatives. It's something that we do in the EPIC EMR, and we find it successful because we're doing the outreach where prescribers are in their day-to-day. So that's something we'd like to investigate. We'll continue to publish our pharmacy pearls. And, exploring clinical decision support in the EMR is something that we're interested in doing as well. It would be nice if we could support, decision-making around maybe real-time benefit checks in the EMR to avoid getting a prior authorization down the road. Or, if we were working on a heart failure protocol together, is there a way that could be driven by the EMR? Katie also did an excellent job for us updating our working with Kevin Kelly. So Kevin and Katie, this is their hard work you can now find a landing page for pharmacy pearls that is categorized by disease state for quick access if you remember seeing a topic that we put out that you wanted to go back to. So we're moving on to key strategy 2. Before I move on, does anybody have any questions? Okay. Does anybody have anything that they think for key strategy 1 we're missing, or that we could do better, or that, looking forward, we could be more strategic about? I know you guys want me to go on vacation too, don't you? All right, thank you. All right, so key strategy 2. This one is, the integration of clinical pharmacists into ambulatory team-based care, so our embedded model. So currently, we have a team of 8 pharmacists that are embedded in 10 practices across strong Highland and private practices. We have pharmacists in 2 of our private practices. So this, our efforts here are really to design a standardized ambulatory practice model around comprehensive medication management, where a pharmacist is integrated into team-based care in the primary care offices. We want to also support the clinical pharmacists as well as practice teams in implementing this model. So we've come together in this, what we call the one team approach with URMC as well as AHP to bring all of the pharmacists together and to create a supportive environment for continuous learning for the people that are doing this work, the pharmacists specifically. There's a lot of tools around comprehensive medication management. There's literature out there from larger programs that have been in existence in both Minnesota and North Carolina that suggest, as I mentioned previously, that having a pharmacist as part of the broader team in primary care can help contribute to the quadruple aim. And there was a national research grant that was done by one of the pharmacy organizations that put out a lot of tools to do this work. So that includes having the pharmacist conduct practice management assessments annually to find areas of opportunity to move to a more ideal state, so more towards fidelity to the practice model in areas that might be feasible to work on. So some continuous improvement in the practice model. Also, we conduct routine team meetings with all of our pharmacists together to work on things like, any clinical issues that they're having, practice management support. Right now, our big push is going to be around optimizing fidelity to the model. So pharmacists can conduct every 6 months self-assessments to the patient care model to make sure that they're following as they should be the CMM patient care process when they're working with these patients. We're also trying to do a good job of telling the story of adding pharmacists to the care team and understanding what the story is to tell. And we want to understand both patient and provider experience. So again, Katie's name is going to be mentioned here because she's helping us to work on developing and validating a provider satisfaction survey for the providers that are working with pharmacists in the practice. So I mentioned a bit about the one team approach and fidelity. So for this slide, really, we also want to work on an analytics plan to support the value of CMM. We'd really like to expand the model to other practices because our early experience so far is that it has been a good one. From what we're hearing from providers qualitatively, from what we're seeing from the data that the pharmacists are collecting and patients that they've worked with, we're seeing improvements in patients moving from uncontrolled chronic disease states, diabetes and hypertension specifically, to controlled after engagement in CMM. We'd also like, Elisa and I have already talked about, understanding how care managers and pharmacists and practices engage with each other for these high risk complex patients. So that's something that we're going to be working on. And so basically the slide is about, we want to expand it. We want to make sure we're doing it well, and we want to figure out its value to share back with payers that are funding some of the salary. This was a little story that we put together during pharmacy week. This is the team of the pharmacists that I've talked about. So obviously Katie and Jenny, our AHP funded pharmacists, are on here, as well as pharmacists funded through Strong and Highland. And so we were excited. So we put this together to celebrate their accomplishments. Let's see. Other things that we could do to expand this model is thinking about the use of pharmacist extenders. So having technicians maybe help to schedule patients or do the thorough medication histories before patients come to clinic. Figuring out what is the funding source to get more pharmacists is probably important, they tell me. And that's really it for that slide. And then the last is the key strategy around the medication use system. And we're still sort of on the tip of the iceberg with this. One of the things that we want to do is engage with you of our pharmacies to better work in our AHP pharmacy cost savings initiatives, take some of the burden, off the practices and have the pharmacies help us. We did this with Wegmans with Humalog, and we believe it was successful. We also want to brainstorm those ideas to start tying the medication use at the pharmacy access and adherence to our CMM model, which we've been approached by both Wegmans and U of R to partner in some way going forward. And this is just what that's talking about, of if you get the optimal regimen and you have optimal use and the two things are working hand in hand, that's really when you can achieve medication optimization and contribute to the quadruple aim. So an important piece. So in 2021, what you can expect is that, right now we have a platform of pharmacy initiatives with cost savings potential of around $4 million over the year. We are working on standardizing those metrics to go into the provider engagement report around these initiatives to feed back information to you. We also have been developing a process to identify, explore, and address the impact of new drug approvals, expanded indications, or new or increased drugs in our population. That was the report I was talking about of drugs that cost $250,000 or more. We want to, with our overall AHP and URMC model, reach within this year 1,000 patients with CMM across all of the pharmacists. We're continuing in the fall. We'll start to work with Christy again to develop an analytics plan for ROI for the CMM model. We continue to market and brand the role, scope, and value of pharmacists providing CMM. And we're starting to initiate partnerships with few of our outpatient pharmacies around and vacation, around tying the medication use process together with CMM. So with that, does anybody have any questions or comments, things they'd like to see? You can share them with me offline as well. You can just hit me up via email. I'll read it after vacation.
So I think being one of the practices that has an embedded pharmacist has really shown to me the value of having a pharmacist and how it enhances patient care. I could certainly give multiple stories about how that works. So I think that being, key factor number 2 is excellent, because allowing us to give a more patient-centric care is always what we look for in primary care. And so I think it's a wonderful experience. I think everyone should be able to experience that. So definitely a good plug for Erica, for your team, and for Katie, who does a phenomenal job at our office.
Thank you so much.
Any
I know.
other for Erica?
Yeah. What'd you say? Oh, anyone else have anything for me? I know Katie's on, I think, on the phone. I don't know if you wanted to add anything, Katie. Oh, how amazing you and Jenny are.
Thanks for all the comments. It's kind of probably hard to hear me because I'm at a swimming lesson right now, but yes, I think it's been a great experience being in the practice, and I hope that it can expand from here so that more people can experience it.
Great. Thank you very much, Erica. If anybody has any further questions for Erica, please feel free to put them in the chat, and we'll answer those as we go. So following our agenda, Willie will discuss the 2021 Arcadia measures overview and discuss Arcadia, that wonderful electronic system.
Wow, no sarcasm there. So it's going to be me and Chad. So we'll be talking about the 2021 measures. Chad will share the performance through March and provide overview of this year's measures. I will then review the thresholds and definition changes, and also what we're currently seeing in Arcadia and what to expect moving forward. And lastly, I'll talk about working together on data issues. So next slide, and take it away, Chad.
All right, thank you, Willie. So this is something that we got used to showing you guys previously, and then obviously with the pandemic, this took on a little less importance in everyone's life. So now that we're kind of shifting back to hopefully business a little bit more as usual, we wanted to bring this back just to give everyone a sense of where we're starting from. Now, no surprise or shock, 2020 was a tough year when it came to overall metric performance, especially for those things that required in-office visits and or the preventive screening visits, because let's face it, for about a quarter of the year, most of us were functioning under very reduced or completely absent in-person office visits. So no surprise that our performance would trail off. If you remember looking at these gauges, the silver needle is where we were, the black needle is where we are. Going clockwise towards green is beneficial. So the adult preventive measures, those are going to be your colorectal cancer screening, your mammography, your diabetic eye retinopathy screening. The adult disease management, that's going to be hypertension, blood pressure control, diabetic A1C less than 8. So each of these compasses represents a cluster of metrics. And as you can see, compared to 2019, our overall performance is down, no surprise, in 2020. Now, always being a glass is half full kind of person, the benefit of this, I think, is twofold. Number one, we should be able to move back to the silver needle very easily. Number two, the farther that red needle goes into the red zone, or that black needle goes into the red zone, the smaller the hurdle that we have to step over to win contractually. So our performance doesn't have to move as far to maximize our gain share earning in our contracts. So I anticipate for many of these, we will see a nice rebound, but you will see that our metric grid for 2021 is very, very similar, and in fact, more contracted with less metrics than what we've even had to deal with previously. Next slide. So when we look at the updates, this is now somewhat old hat for everyone. Remember, on our contracts, we have the measures, and then we have an assigned point value. That point value is a little bit of a bilateral negotiation between us and the payer to ascribe how much we're going to value one metric against another. You're going to see one of our goals has been to unify and kind of homogenize that point assignment, both so that we get equity between the adult and pediatric measures, but also so that we kind of assign equal value to all of them, because if we're going to put them on the grid, we think they're important for us to work on as a network. The thresholds really do not change. So the thresholds and the percentages that you have to achieve of performance, the number or percentage of your patients who are applicable, who meet the numerator to qualify for the metric, is based on national and regional benchmarks that are really put out in October, November of the preceding year, which is to say our performance in 2020 was set, or the thresholds were set in 2019. So there was no amelioration or change during the pandemic. And likewise, the changes this year theoretically took into account some of the pandemic effects, but oftentimes these changes in benchmarks have to do with years of predicted evolution, kind of an actuarial assessment of where they think performance will be as a nation. So this is not us competing with ourselves. This is not us competing with the folks down the street. This is us competing against the entire nation as everyone tries to perform better at these metrics. And these are national HEDIS metrics. So these are nationalized metrics. This is not something that we at HP dream up in our sleep to just make life harder. These are actually widely used metrics across multiple value-based and healthcare organizations. Next slide. All right. So what you see here is our grid for this year. So all of these metrics, as you will see, have been assigned previously. The new metric with the paint swash going across, fall risk management. Many of you may look at that and say, wow, that doesn't seem new. I think we did that before. You are correct. So in 2019, this was actually on our grid. We went from 25th percentile to 90th percentile in really about an 18-month window of time. And the payers really de-emphasized, and in fact, Excellus took fall risk management off of their grid for active consideration in 2020. So that was part of our negotiation, and that was the reason it did not appear on our grid last year. However, this particular metric has now become emphasized by CMS for star rating for Medicare lines of business, such that the weight of this metric for payers with CMS is double the weight of other metrics in the CMS HEDIS world. So the payers went from don't want to negotiate for it at all to you must take this metric in 2021. Not you must, but they really, really, really wanted it. Fortunately, thanks to the work that Kim Povic and Elizabeth had done, we had already set up infrastructure to really perform very well on this metric already. So we felt very comfortable adding this one back without much difficulty. A couple of things you'll see in a moment. There are fewer metrics than what we have danced to in the past. Our goal is to try to confine this list to the metrics that we think are both important for patient care, but metrics that we also think that we can substantively and meaningfully move the needle on. So every year we try to confine that list and to unify our metrics across all of our payer contracts so that we're not dancing to a host of metrics being different from one payer to the next. The other thing that you will see this year is that we have assigned an equivalent point value to every one of these metrics. The reason for that is several-fold. Number one, we have tried to balance the number of points available for peds and adult metrics. Number two, we wanted to homogenize, as I said before, the importance of each of these metrics. And so we essentially, for the first time, were able to add equal weight to each one of these metrics going forward. And we think we should be able to perform well to all of these metrics this year. Even for those metrics where we have struggled in the past, we have already put in infrastructure and plans to try to improve our performance going forward into this performance year. Next slide. So these are the metrics that you'll see the changes. So on the right are all the metrics that we dropped. I will tell you, adult BMI nationally and even for our own contracts, we had pretty much pegged the needle on how much performance there was here. And I have to say, we kind of kept this one as long as we could because it was a guaranteed freebie of points because we were doing it 98% of the time. Diabetic nephropathy is one that we have historically struggled with. This metric got sunsetted by HEDIS, but they introduced a new metric, which is very similar, that will come back likely within the next 1 to 2 years. However, because that new metric has no thresholds assigned to it, there was no way to put it on the contract this year. So that's why it's temporarily fallen off. But you will likely hear us coming back to you in 12 to 24 months to tell you that the new and improved diabetic nephropathy is back in business. Imaging for low back pain, this one had been the toil of several years of HP existence and work. And we had finally achieved about all that we were going to be able to achieve in this domain. So while I still think that this is important for appropriate care of acute low back pain, the metric was no longer really driving performance any longer. And so the necessity of keeping this on the grid and the value really just wasn't there. Finally, well child 3 to 6, HEDIS has decided to change the well child metrics to engulf the entire age spectrum. So again, because that new metric has no thresholds assigned yet, it is not active, but we are likely to see that one come back within the next 12 months as well. But it'll be a pediatric 3 to 19 or 3 to 20, I can't remember. So we'll have to see how that one looks. And most likely that will be heavily favored for us to take that back by the payers. We'll see how that goes. Fall risk I've already addressed. So it is the only new metric you will see this year, but it is kind of an old friend that's just coming back for an encore performance. So that is really the changes we expect to see from a grid design and how we got to our point assignment. So now I will turn it over to Willie for all of the nuts and bolts nitty gritty about how well we have to do to achieve the 90th percentile.
So all the fun stuff.
That's
So I think that new well child is going to be 3 to 21.
21, there you go.
Yep. So looking at the thresholds for 2021 and the change from last year, I'll just go through them. There's not many. Adolescent immunization combo 2 went up the most at almost 4%, still relatively low at just under 40. Breast cancer screening relatively unchanged. Childhood immunization combo 3 up almost 1%. Colorectal cancer screening up over 1%, 75. Diabetic eye, A1C, and fall risk management basically unchanged. Fall risk management unchanged from the 2019 threshold. Hypertension, blood pressure control up 0.5%. Lead screening actually went down over 1%, and the well child went up 1/3%. So some flux, but not too bad. Next slide. So there are 4 changes of note that affect 5 measures. The diabetic eye and A1C measure were both affected by HEDIS removing the restriction that only one outpatient visit with a diagnosis could be telehealth, telephone, e-visit, or a virtual check-in. So you can have 2 outpatient visits in those categories now. Specifically for diabetic eye, the AI interpretation now meets the criteria. So they're moving into the 21st century.
However,
the biggest change was actually hypertension, blood pressure control. The time frame where they are looking for outpatient visit with a hypertension diagnosis changed from the first 6 months of the measure period and the previous year. So where in 2020 they were looking at the full measurement period in the previous year. So last year when a patient's second diagnosis came late in the year, there might not have been time to react. So that patient would end up being a gap at the end of the year. This year, you won't run into that situation. So pretty much your denominator at the end of June will be your denominator through the end of the year, which is good. They also removed the restriction on the types of outpatient visits with hypertension diagnosis, similar to the diabetic measures. And then they opened it up when, who, and how the blood pressure readings are performed. They can be taken during all types of outpatient visits with any digital device, and the patient can take and report the result. Lastly, with the well child measure, telehealth visits now count towards satisfying the measure. The other definitions remain virtually unchanged. Next slide.
Actually, Chad, why don't you make your point that you put in the chat?
Yes, just
sorry.
to point out, so even though we are super cool and with our diabetic eye camera initiative, we do have the cameras that do have AI point of care interpretation. New York State still does not allow for AI interpretation for billing and coding purposes. So it still must be interpreted or overread by a New York certified ophthalmologist to count in New York State. So therefore, HEDIS is a little bit ahead of the New York State rules at this point. We are hopeful that the AI will be allowed to stand on its own. The data would say the AI is equally or better than human interpretation. But for the moment, while it would be allowed under HEDIS, it's not allowed in New York State. So we're still stuck with ophthalmologist interpretation for now.
So I'll make that change.
Well, no, you're right. That is correct. But
Yeah, but if,
New York State just doesn't love us.
right. So let's follow the state rules, I guess. So now that we told you about the 2021 measures, we'll talk about what you're seeing in Arcadia. So currently in Arcadia, you're seeing the measures HP chose for 2021 with updated thresholds and points. However, until the next Arcadia upgrade, the 2020 measure definitions are being used. So we wanted to put something out there and not wait for the 2021 measures to be available. The upgrade is tentatively scheduled for mid or late July, at which time the 2021 definitions will take effect. We know that waiting until July for measure definitions isn't ideal, but there's a light at the end of the tunnel. So coming with this year's upgrade is a new Arcadia measure engine. Measure engine removes the need to wait for an upgrade to get updated definitions. So if it is as promised, we are expecting that next year's definition should be available shortly after the claims rollout. So hopefully we can push the timeline for having new measures up 3 or 4 months. So there is good news if they come through. Next slide. So how do we work together on validation? Something near and dear to my heart. I request that somebody at your practice looks at the dashboard on a regular cadence, daily, monthly, quarterly, whatever works for your practice. As soon as they see that performance in Arcadia doesn't match what they expect, let me know. When they see that a patient isn't closing a gap and should be, let me know as soon as they can. We don't expect the practices to spend hours researching why patients don't close gaps. Let HB or let me do that for you. We want you and your practice concentrating on the great clinical work you're doing, not on gap closure. So let me take care of the investigation by working with Arcadia, the EMR vendor, and your practice. Lastly, for some reasons why performance may look off from time to time is due to data delays. Freshness of the data depends on how frequently the data is provided to Arcadia from the EMR. After Arcadia receives it, it could take up to 4 days for them to process it. And then the prior month claims are loaded between the 20th and 25th of each month. And then lastly, for our security officer, a reminder to your practices to not send patient PHI data over unsecured email. If the practice has no way to send a secure email, just send me a note and I'll send a secure email, which then can be used to reply back to with the PHI data. And that's all I have. Any questions?
Yes, Willie. One of the things that I find frustrating as a primary care provider is the fact that it took 6 months to download the data into Arcadia, especially for things like diabetic measures and a lot of these things that we have to do on a yearly basis. Right now we have 6 months to be able to correct certain data points. is this something, do you think Arcadia moving forward is going to be able to modify and give us 9 months, 10 months to be able to identify these and move forward?
Right. So you're referring specifically to the new definitions or the updated definitions?
Correct, right? Because now we're in June or July and we had nothing in Arcadia to go by. We had to go by whatever, we know, but we can't identify some of those gaps that remain open that we would find through Arcadia normally.
Yeah. So with the new measure engine, that's going to be pushed. The measures won't be tied to an upgrade. So right now we can't take new measures without an upgrade. With that measure engine, hopefully that'll get pushed up to, I'm hoping, March.
So giving us 9 months, which seems much more logical for things like diabetes. It takes time to correct, right? Because if you give us an abnormal open gap at 9 in October, very hard to close that gap by December,
Absolutely.
right? But if we get that number in March, we have 9 months to be able to really work with that person, and make changes. So that is something we really should push for, is having that piece, right?
Yep. And as ever since I started AHP, Christy has been on Arcadia, trying to decouple the two. Why should we wait for an upgrade to get our new measures? And finally, they're coming through with decoupling the two.
One other thing that's changing that is going to help that, and it's not just Arcadia, is NCQA has changed their schedule for publishing the definitions. And we're in the midst of this transition period, but we've already received the new definitions for next year, for 2022. So that gives Arcadia plenty of time to program those, whereas before they were getting them in November, and it would take them well into March, April, thereabouts, to get them and get them certified and tested and all. So all things are looking positive at this point. Our fingers are crossed that next year's better.
Absolutely.
Christy and Willie, what do you think about the speed of Arcadia? Another big complaint of both on our population managers are the speed of Arcadia, not being able to really, having to do some other work while you're downloading a report or downloading gaps. How is that something we can, efficiency is something we all look in our practice to maximize.
Can you answer that one, Willie? I know there's some days where I'll go in and it seems to be running a little slow, like today seemed to be a slow day, but I don't know what your experience is, Willie, if there's some things that we can do.
Yeah, personally, I don't see it because I'm not running reports and things like that. I'm just, but I'll mention it to him.
I think it's been an issue for the care managers too.
Yeah.
So.
I don't know.
Yeah. And then lastly, I would say that one of the things that we really need to look into, and I think it's very EMR specific, is, depending on what EMR we have, whether the data is downloaded accurately into Arcadia and how we can close some of those measures. So for example, as you probably know, Willie, in our practice, we have a lot of A1C manual inputting, and we have a lot of fall risk manual inputting that has to go on because they're not jiving correctly. How is that? How are we dealing with some of those issues for this coming year?
So for those two issues, I think we have tickets into Arcadia, and they've been open for about a year. With the newest upgrade, actually some of those issues are going to go away. But it's just working with your practice and working with Arcadia. They've a lot more responsive to our tickets and are responding. So hopefully we're a little quicker at this than we were in the past. It took me a while to get up to speed on all this.
Thank you.
Sure.
Anything from the chat you want to elaborate on, Chad, or good?
I don't think so. I've tried to answer the questions in the chat as much as possible so as not to interrupt the conversation. But I think the questions in the chat about home blood pressure monitoring, this is now the recommended way to manage blood pressure. And we're going to be talking more and more about blood pressure management for a couple of reasons. Number one, it continues to be kind of one of the sticky widgets as far as adult chronic disease management. because there is a lot of permissive hypertension. Number two, from our own data, we all have kind of talked over the years that we expected our gaps to be in the poor, the rural, those who do not follow up in care, the urban inner city. However, when we look at our data, our largest gaps in care are in Brighton, Pittsford, Victor, Webster. So doesn't really fit with any of those groups necessarily. So I think what we're seeing and what we have started to see across the country is not white coat hypertension, but this permissive white collar hypertension, where we see the 55-year-old executive or the 53-year-old business owner who comes in who has a blood pressure of 152. They say that they've been anxious or they were, kind of hurried trying to get to the office, and that's why their blood pressure's up, but it's always fine when they're at home. And then we just say, okay, yeah, don't worry about it, you're fine. And I know that because I say that all the time. But then they go home and their blood pressure is still 153 and 152, and it doesn't really change. So I think trying to address that is going to be key. Number two, and I'm not saying anybody on this call, people just don't know how to check blood pressure, realistically. The number of people even, that come into the hospital in the office that have a respiratory rate of 18 and a oxygen saturation of 98% and a blood pressure of 128/62. They're so vanilla that they're almost mannequins. However, if you actually go and repeat that, oftentimes it's nowhere near what the tech staff is getting. So that's a problem. Three is, this is one of those metrics where we have to start to play defense. So because of the SPRINT trial and because the national guidelines are targeting lower goals for blood pressure management, the HEDIS metric is still targeting a 140/90, but I anticipate in the next 12 to 24 months, we're going to see the blood pressure target drop closer to that 130/80. So if we're struggling to keep the 75th percentile at 140/90, we could suddenly be in a world of hurt if it goes to 130/80. So all of those reasons are things that we're going to have to continue to work on. And so we're going to take this year to kind of deep dive and really focus some attention on blood pressure management. But home monitoring and recording of those home readings is probably a much more fair and accurate reading than what we get in our office when we drag the patient out of the waiting room. We ask them a bunch of very personal questions and we sit them down and put a blood pressure cuff on and measure it. So more and more, I think that should become the staple for that metric and for how we deal with blood pressure in our populations.
And just to reiterate, those changes to the definition won't take effect in Arcadia until after the upgrade.
Right.
Right.
Any other questions for Willie or Christy or Chad? Okay, with that, we'll go on to Renee talking about the upcoming incentive and payment plans for the primary cares.
Okay, this will be really fast. Not that I have the excuse of being on vacation tomorrow, but I'll still keep it fast. Just want to keep everyone up to date of just some recent payments and upcoming payments. So when these payments hit accounts, because we're now almost exclusively paying all of our primary care providers electronically, you'll be on alert as to what these are. So earlier this month, May 12th, practices received a FLIPS JOG incentive. These are our private primary care PCPs received this incentive for their efforts in the FLIPS JOG. We first contracted with FLIPS back in 2018. We continue to earn dollars from FLIPS for that work as your good work has perpetuated into them getting more dollars for some of these initiatives, and then they share it with us and we share it with you. So this was paid out to providers on May 12th in the amount of $1,100 per provider, and that was paid electronically. And we do always as well send a payment detail sheet via email with an explanation, of the payment. Just today, some payments were made to some practices. This is a new maybe kind of a one-time incentive to recognize practices who have agreed to work with the vaccine hub or the Department of Health, or even if they're getting supplied directly from the state, but to administer the COVID vaccine in their practices. So we wanted to recognize those practices, provide an incentive as a thank you, and also as a way to cover some, I mean, there's even with all that support you're receiving, there's a cost in time and materials and effort to do this in your practice. So practices were paid in the amount of smaller practices, just 1 or 2 providers received an incentive of $1,750. Practices with 3 or more providers received an incentive of $3,500. So those payments will probably hit accounts tomorrow, and the email notification went out this afternoon about those payments. So if you're in private practice and you're not currently choosing to vaccinate for COVID in your office, you will be eligible for this incentive. I know it's not a huge amount of money, but if that pushes you over the edge, let us know that you've started, and we'll be happy to connect you to that incentive. And then finally, next week, practices, our private primary care will receive their first quarter 2021 clinical integration. So this is that $1 per member per month for every attributed member covered by Excelis or MVP, all lines of business. For those providers who are U of R employed, your employer receives those CI dollars. So they are paid, but they're paid directly to the primary care network or to Highland Hospital or to whomever. So next week, practices can expect to receive that first quarter 2021 clinical integration. And that's all I had to say, other than to remind folks that we have the summer off, and our next meeting will be August 26th. So have a good summer. That's all I have, Diego.
Okay. Does anybody have any questions, topics they would like to address? Particular? No? Okay, good. Well, good luck to Kevin and the new endeavors. Welcome to Alyssa for joining us and heading our care management team. And if any questions come up, always feel free to email Steve Judge, myself, Renee, or Chad for this committee meeting if there's a topic you'd like to put on the agenda. And with that said, have a phenomenal summer and a very happy Memorial Day weekend.
Bye.
Take care.
Thank you.
Have a good
Good
night.
night.